regular occurring things that are not the trauma as well, nor are they deteriorative but more activity-related things. Tendinitises are obviously very common. De Quervain's tendinitis is varying forearm muscles and tendon groups. You've all heard of tennis elbow as a problem. Depending on what, again, the causes of these conditions are, how long they've been going on, what type of person it is based on what their demands are, what other things they do, what their age is, and what their goals are. Sometimes we can be effective at either managing it, and if not managing it and controlling it, then at least referring to other resources that might be able to help them. And again, educating them too on modifying some activities. Because sometimes it's as simple as modifying to then really resolve a condition. Some conditions that are more chronic, especially with tennis elbow, once they become chronic, they're really beasts to try to treat. So sometimes guiding them on activity modification and helping them manage the symptoms, but then also referring them to what other resources might be available to them are important that they might not otherwise know. Post-surgery conditions, like I was saying, there's a whole host of things that we would, again, see. And not so much that it has to relate to these specific conditions, but just the idea that any hand surgery that's been done on someone, there are things we can do earlier, whether it's related, again, to amputation revisions, joint fusions, joint replacements. Simple things like ganglions being removed from a wrist that normally you wouldn't think would need a therapist involved, but again, their close association with tendons and nerves in those areas can create a lot of other accessory problems for people. So it's the trauma of the surgery getting rid of that ganglion that can sometimes create the painful responses or the swelling responses that can then even contribute to tendinitis, for instance, in that immediate area. So we can help control those things early on in an ideal situation. But there's a lot of types of conditions that post-surgically we would again be very valuable in treating. I kind of highlight the tendon repair idea and tendon transfer idea. A lot of those things are so critical to get seen early within 24 to 48 hours after a tendon repair surgery to get the early protected mobilization and to prevent things like tendon adhesions or tendon ruptures. And again, I find that educating the patient is the critical thing that they're often lacking because they've been traumatized, and as much as the surgeon educates them when they're in there doing the procedure or after or before, because they're so traumatized and distracted with everything and worrying about, okay, now I gotta have this surgery, I gotta have this thing casted and splinted, what am I gonna do for work? They're so distracted a lot of times that it's not till later on when those things calm down that they can then really listen to what the recommendations are to not actually create damage to the surgery that was done. So again, early on is really the advantage. Some of the evaluation tools and techniques that we use, I'm sure you're all familiar with, goniometers. We have different sizes. There's different types for different finger joints. So we measure things to give us a baseline of, okay, what is your motion when we start? What is your strength when we start? But that's not really our final outcome judgment of success, like I was saying earlier. It's really giving us a kind of a treatment parameter guideline to kind of give measurement against so we can judge, listen, are these things and tools we're doing, are they effective? Let's measure. And if they're not really resulting in different measurements, well then maybe we change our strategy a little bit. So they're really tools to give us guidance on what we're doing and to give feedback to people, but the more important thing is what are we regaining for function and ability.
I hate to admit this, Mark. I work at a clinic where we use those tools, but I've never seen them used.
Right.
Can you give us a little demo on that?
Absolutely, we can do that. I brought different sizes of them here, and maybe David, if you don't mind coming up here for using your list as a sample.
That's not what I was after, Mark.
Yeah, I know. You're such a great, a great model. So if you don't mind rolling your sleeve up.
Let's go with the good one.
So yeah, sure. So you can obviously see. I'll just roll this up just to show them maybe your wrist here a little bit. That's fine. So if I was to measure, for instance, David's wrist. And I wanted to just measure the flexion or extension. So typically what I would do is I'd have him sitting down, resting his elbow up. And then what I would do is take one of these goniometers. This is a large one. He's, a large guy, so we could use this to get a good idea of where his bony axes are lining up. This is a common one I'll use for wrists as well. But again, you can see it's a little smaller arm here, so with someone with a really large arm, the longer lever I have, the more I can line up and estimate where his ulna is going to be underneath the skin. So what I would then try to do is I would hold it in place, kind of line it up with the long bone of his forearm, which on this side is the ulna. And then what I would say to David is, David, can you please bring your wrist backwards as far as you can for me? So this is what we would call, I'm measuring his active motion. So he's doing the motion on his own. I'm not doing it passively. So I'm going to now take that arm and I'm going to line it up with, we'll just kind of rotate so maybe they can see a little better that way. I'll just torque you into this position. I'll create some injuries, then I'll have to see me again. It's not a bad idea. So then you can kind of get an idea of, I'm lining up those axes with the metacarpals of his hand and with the long bones of his forearm, and that axis is right where that joint is moving. So then if I remove that, I can see that that measurement is about 65 degrees. So that's what I'm measuring when I'm measuring an angle of a joint. But essentially all measurements are angles of how much the joint is moving in degrees. So for instance with David's other hand, because he's got some stiffness there, we won't necessarily have to measure it, but let's say that I measured his active range of motion as 35 degrees in the same direction. So let's say I measured it as 35 degrees. Because he's got the trauma there and the stiffness and the other components to that injury that he's having to deal with, I will also then want to know what is his passive range of motion like. So what I will then do is, first of all, I will start with the active motion to see what his pain response is like. If he's very painful, I know that I'm not going to push very hard with the passive motion. But let's say I measured his active motion as 35 degrees. And then let's say that I'm doing his passive motion. Maybe I'll just demonstrate that just for the purposes of visually seeing it, sure. So David's done his active motion. So now what I'm going to do is I'm going to now stretch passively David's wrist until he tells me that that's about his maximum. Is that about your maximum there, until your pain stops me or until the joint stops me?
I have a high tolerance.
Well, good. I'll just
spend it all the way back.
I may need some help.
Just don't break it.
Yeah, exactly. You've done that once already.
Yeah.
So now what I'm doing is I've got to, let's say this is your end range of your motion. So he's telling me, you know what, I don't want you to go further, or I'm feeling that I can't go further. So one of those two things is going to tell me to stop. And then what I'm going to do is I'm going to say, okay, his passive motion now is 70 degrees. His active motion earlier was, as an example, 35. So why is there a difference? The joint clearly can move through a different range, whether he's doing it on his own or whether I'm doing it. So that tells me that there's probably a tendon and muscular issue going on, weakness, or a lack of teaching those tendons and muscles how to actually make that movement occur again because of a long time of immobilization, for instance, where they've lost their ability to even know what the heck they're supposed to be responsible for. So the difference between active and passive motion, measuring in degrees, can also then in my evaluative kind of strategy tell me what I also need to work on. Not just getting the joint moving, but also then reteach this musculoskeletal system to move on its own, because one can move better than the ability to move on itself. So active and passive motion, again, measuring in degrees, can give me different goals. So that's some of the examples of how we would do it.
I'm glad you explained that, because I've seen those things in our office, but I've never seen them used.
I was telling you about the surgeon I worked for in Arizona. He was a very proud guy, and he'd been around for a long time, and he claimed that he didn't need to use any of these things. He could eyeball it in and be within 3 degrees. So we would always challenge him on that. And he was pretty darn close. So we didn't really challenge him on that. But what I see a lot is I see patients that I get a report, for instance, you know, from whoever their attending physician may have been, and there'll be an approximate degree motion listed in a report. And I asked them, I said, well, did he use one of these? And I said, well, no, I've never seen one of those in my life. So when I see that the approximation has been done, then I'll be sure to measure very specifically. Because approximations are close, but you know, I tend to want to get accurate because of what I want to then show people is how much they're changing. They need that feedback. So it's definitely accurate to do it accurately if time permits, obviously. But again, each professional has a different strategy, and in my instance with the surgeon in Phoenix, he was pretty darn accurate. This little guy here, a little differently with the fingers, is a lot of times when I measure a finger joint, especially the small joints in fingers, they can actually have a lot of hyperextension as well. So the joint doesn't typically just go from 0 degrees, which we call straight, into whatever flexion amount we're doing. And in most cases, that joint will be, let's say, 110 degrees. So this tool allows me to also measure in people, not so much in me, but a lot of people can hyperextend a lot of these small finger joints, and a lot of you might as well. So I can actually then keep measuring in the same plane of my tool because I've got a hyperextension component to this little device. And usually those are unique to the fingers. So that's a little bit different in how we would then measure each digit, comparatively to a large hinge joint like a wrist or an elbow, for instance. Trickier joints like forearm motion, supination, pronation, those are harder to gauge because it's not really a tool that we can kind of hook on there to twist and measure. So what I do in that sense is I will measure one axis up, aligning as if it's matching where my spine is, and then I'll align the other arm of this to match where maybe my forearm is turned. So that's kind of how I'll align that and measure some of those unusual joints. And we don't often think of a forearm as a joint, but it actually is, because it needs to rotate. And it has nothing to do with how much the elbow is moving or how much the wrist is moving. It actually has to do with its own ability to rotate on itself. And that's another very common problem that people with, I can use David as an example, wrist fractures, especially wrist fractures that have had surgery, forearm rotation is a big problem. It's usually supination and wrist extension that are the big clinical problems that I see. But he's been really good, he's got it all down.
Why don't we pass those around?
Yeah, absolutely. Yeah, pass them along there. So that's, in general, goniometers and measuring motion, active motion and passive motion, two different types. Strength testing. You've probably seen these kinds of things around too. Grip dynamometer. A lot of times people refer to it as a JMAR. That's a brand of the type of dynamometer. There's lots of different brands out there. But in general, you'll see 5 different increments. And this handle is adjustable to 5 different positions on this JMAR. So we can make it move all the way out to the end where someone would have to really reach their fingers to give a squeeze on their grip power. Or, as it was earlier, we can put it really far in to then get a gauge of what their tight grasp is like. In general, when you see these in an office or clinic setting, the second setting on this dynamometer, there's 5 in total, that's the setting that all the research has been done on as far as comparative norms. So when you're taking measurements as a routine to get a standardized measure and maybe compare it to the norms that are out there for someone's age or gender. So if you have a male who's 55, you can look up the norms actually and say, hey, a male who's 55, what is normal for that person? So you can look up the data on that. But if you change the positions, those normative data numbers don't match. So that's why the second position is what we call the normal normative data position. But we might use all 3 different positions depending on the type of injury. Let's say a tendon laceration to one of the tendons that goes to the tips of the fingers. I might want to extend that grip to measure what their real stretching out grip is, more just using the tips. So again, I can adjust this depending on what my goals are in therapy, what I want to measure, and then how I want to calibrate and adjust my treatment along the way. So I'll pass these along the way as well. Some of the things that...
Does it make a difference on the size of the hand?
A good point, it does. And that's where, again, the normative data doesn't take into account the size of a person's hand. So someone with a really tiny hand is going to fall into those data norms on the lower end. Okay. Someone with a really large hand will fall into those data, but they're not going to be able to exert as much strength because they've got this massive mitt that they're using to grip. So those are going to fall outside of really what those norms are for them. But again, clinically, what I'm doing is saying, okay, listen, if you've got a really tiny hand and your hand is really stretched out and you're trying to grip number 2, for my therapy purpose, I might adjust it down to setting number 1 and say, hey, this is our starting point for where I want to establish a baseline. So again, I judge it based on what I'm trying to accomplish. For certain things like functional capacity evaluations, where there's a lot of testing of validity and comparing to norms. That's where we just got to be real careful if we're comparing to norms, that we have to be in the proper settings. A lot of times, and one of the other tools, since we've alluded to that, a neat thing that we do too with these different norms, some of the data that suggests validity testing in people, each of these increments, if you take 1 measurement of each or 3 of each to get an average, if you plot the number of And again, it's a pressure gauge, so pounds per square inch. PSI is really all this is. It's just a standard pressure gauge. So as you plot this pressure gauge, if I took measurements of each setting and I plotted them on a graph, what you would see is the first setting would be really low, the second setting would be higher, the third setting would be probably higher, and then the fourth would be a little lower, and the fifth would be a little lower again. So I would create a bit of a bell curve with each of these settings if I did that on somebody. Again, injury, pain, those kinds of things can affect what that shape of bell curve looks like. But when we look at validity testing, for instance, in a functional capacity evaluation, if we don't see a bell curve, that's sometimes indicative of either lack of effort or some other parameter that's affecting full actual performance. But sometimes in an acute phase of injury, that can definitely not be a nice shaped bell curve. It will definitely be flatter because of pain, because of lack of motion. All of those things need to be taken into effect. But that's a very versatile tool that we use clinically to either measure use as a baseline to measure our success, but also for some of the validity testing that's out there in the healthcare world. So I'll pass this around as well. The other thing to remember when you're experimenting with this is when the standardized position of using this grip dynamometer is, elbow 90 degrees, arm by your side, and squeeze it like that without supporting the weight of it as well. So if you're doing it to somebody, make sure that they're at least in this standardized position so that they can give you comparative data. And I always tell people is even if they can't do it for whatever reason medically, like maybe somebody's got a really bad elbow injury and they can only bend their elbow this far, well that's fine. But as long as you're doing repeated measurements over time, because in the same position, then you're okay to compare what your goal is from the previous position. So I'll pass these around as well. So that's the grip dynamometer. Similarly, that's a pinch gauge, and there's varying types of these out there, but same idea, pressure gauge, and there's a few different types of pinch pressure that we would measure. The standard one is using your hand over top like this, and I always tell people it's like if you were holding a piece of paper, I'm going to pull it away from it, don't let me. So that's how you would pinch that, and that's usually our power pinch in life. So that's how we would then measure that particular pinch power. This one isn't so dependent on elbow position and shoulder position because you're using the smaller muscles of your hand. But that's what we would call a lateral pinch. So that's how we measure that lateral pinch power. Tip-to-tip pinch is another indicator then, and another measure that I'll take. For again, depending what my goal is of therapy. So I'll measure, we can if you want to use all of them. Depending again, what your goal is, what the injury is, and what you're trying to actually assess. What is the information you're trying to gather? So there's a tip-to-tip pinch that we will often do. And when I tell people to do that, what I'll tell them is bring the other fingers out of the way and then grab it so you're trying to create a circle with it rather than flattening out like that, because then they're getting more of that lateral pinch and they're using accessory muscles. And since we've already done that pinch power, we want to more get a gauge of these small intrinsic muscles and how they're affecting pinch power. So tip-to-tip pinch, I would define like this. But again, I keep my fingers down because oftentimes people will try to press and help. So it's just a matter of having them be consistent with it because, you want to get as high a measurement as you can. So that's tip-to-tip pinch, again, creating that circle. The other common one that we'll do is using a tripod pinch. So 3 fingers together, again, trying to create a circle to create a tripod pinch. And that's often another power pinch we use because it's our dexterity pinch for twisting, grasping, even pulling. That's another power pinch we use. Whereas tip-to-tip is not really a power pinch we usually rely on. It's more of a fine-tuning one. So the lateral pinch and the tripod pinch are usually our power pinches. Good question you mentioned earlier about the other fingers.
Right, because
yes,
some of us that have got...
They are, and the interesting thing about how our hands are built,
Right.
I'll pass this around as well, you can kind of pass that side to side, is we often, we break down the hand into 2 sides of the hand. So there's a radial side of the hand, this way. So the 2 fingers and the thumb create one side of the hand, and that side of your hand, it really has a designated function, and that's for dexterity. It's for dexterity, fine motor control, pinch, and those are all the fine-tuning things we use. The ulnar side of the hand, which is this way, these 2 fingers, what a lot of people don't realize is that's the side of your hand that you need for grasp power. A lot of times people think that you're using all 4 fingers equally for grasp, and it's not true. The ulnar side of your hand, these 2 digits are really where people get grasp and pulling power from. So oftentimes, getting back to some of the diagnoses like amputations, little finger amputations for instance, some of my guys, truck drivers, things like that, where guys are climbing and strapping loads down, they're surprised and shocked at how little grasp power they get after they lose a little finger. Because they have this assumption, that's just my little finger, I hear it all the time. Ah, it's just my little finger, who cares, how bad can my hand be? And then they realize that, I can't climb. I can't pull that load down anymore, I've got no grip power. And that's the reality, is your grip power comes from the ulnar side of your hand. So a loss of motion or a loss of length or a loss of function of the little finger and ring finger affect the grasp power. So pinch and dexterity on one side of the hand, grasp power for pulling, carrying, those kinds of things are from the other side. So they're very important digits. Even though they're small, they're very important.